morning, everyone. My topic today is going to be around a series of congenital heart defects. Um, Probably most of you knows about the heart defects anatomical point of view. I'll try to go through some points of the hemodynamics and points to comment on during reporting of cardiac MRI or a CT um, of the congenital heart defects that probably are more significant and relevant to the management of the patients. Starting with um, ASDs, as you may know, that there are different types of ASDs: secundum, premium, sinus venosus, coronary sinus, and there is a special type which is considered as an ASD hemodynamically wise, or um, sometimes is being called a leak, which is a special type in cases of mustard sinning after correction of a TGA, where there is a communication between the buffles. So it occurs at the atrial level. So hemodynamically, it's more or less an ASD, but this is a special type of ASDs. Of course, the type and location depends on the development of the septum premium and septum secundum. I'll try from the cross-sectional imaging and the images to see where exactly is every defect. Um, Starting with the ASD secundum, it's the more frequent type, or it's the most frequent type of the four types of ASDs, sometimes even encountered in adult old age patients accidentally discovered while preparing for another surgery, and the echo then reveals an ASD. And ASD is the communication between the left and the right side at the atrial level. And the ASD secundum, where the high pressure is in the left atrium, so blood will shunt from the left side to the right side until a point where, if pulmonary hypertension develops, then either it will be restrictive or it will be reversed, which is an Eisenmenger syndrome. So it's not every time we see a secundum ASD that everyone will be happy. So measuring the size, so the important points to comment on secundum ASD is, of course, the size of the ASD, whether there are margins around the ASD sufficient to close this ASD percutaneously rather than surgically. So if there is an anterior rim and a posterior rim, and then in a short axis view, if we could comment on the superior rim and the inferior rim, where a device will fit in. It's not necessary that the four rims will be available or sufficient. Sometimes two rims will be sufficient. So it's important in the MDT to discuss with the interventionists how easy they feel. The size, usually above 2 or 2.5, is a large. Sometimes they would use two devices. Sometimes they would avoid putting a device in large or very large ASDs where rims are not sufficient and the patient will be sent to a surgery. This is if the QPQS and MRI showed a significant shunt. So it's important to comment on the amount of the shunt, but not only that, because sometimes you would see a significant ASD, but the shunt is small, which is bad news because this might reflect that there is an Eisenmenger syndrome or a pulmonary hypertension. So the next point to comment on, and is very important, whether there is tricuspid regurgitation, hypertrophy, or dilatation of the right ventricle, dilatation of the pulmonary artery. Those are the signs from cross-sectional images that might indicate a high pressure. On a CT, for example, if you see backflow of contrast in the RVC, this might indicate tricuspid regurgitation or volume overload. If you see the septal bowing in MRI, for example, or if it's a functional CT, that the convexity is to the left side or flattening of the septum, this might indicate a high pressure in the right ventricle. All those points are important to comment in the report, either to include or exclude, because this might exclude putting or closing the ASD if there is a pulmonary hypertension or Eisenmenger. A very important point to comment on, whether there is a partial anomalous association with the ASD or not. Premium ASD is whenever you see the mitral and a tricuspid at the same level, then you would be suspicious of having the partial AV canal or the ASD premium where the septum premium anteriorly is deficient and there is a communication again between the left atrium, right atrium. In those cases, usually there is an association of another congenital anomaly, so it's very important to comment on the ASD and to check whether there is associated VSD on the other side. Again, the same hemodynamics like in ASD secundum, how the amount of the shunt, whether there is any pulmonary hypertension on the other side, any associated congenital anomalies, especially VSD. Management of ASD premium, it's a rare form, but it's very complex and is very hard to treat when compared to the ASD secundum, because it involves the endocushions or at the level of the annulus skeleton of the heart. Second type would be the sinus venosus type, which is at the level of the communication or the draining point of the superior vena cava to the right atrium, where the septum is deficient, where the superior vena cava would communicate with the left atrium. And in most of the cases, this is associated with a partial anomalous pulmonary venous return. So one of the right-sided pulmonary veins, either the upper or the right upper and right middle, would drain into the superior vena cava. It's important to say the distance of this partial anomalous to the atrial level. In addition, of course, to the hemodynamic study, whether there is a shunt right to left, whether there is any other associated congenital anomalies, whether there is a pulmonary hypertension, again, those are very relevant and very important to comment during reporting. Sinus venosus defect. So the defect of the coronary sinus usually runs below the mitral valve. So whenever you identify the mitral valve, go below the mitral valve, you would be able to see the coronary sinus draining to the right atrium. The communication could be partial, or could be that the whole or the entire roof deficient. Again, the shunt will be again from the high pressure to the low pressure. So it's going to be from the high pressure left side to the low pressure right side. Again, please try to identify whether there is any associated anomalies associated with the coronary sinus drainage. To summarize, we commented on whether it's CMR or a CT, the ventricular overload, pulmonary hypertension criteria or signs, and to quantify the shunt amount. So when you see a significant ASD but the shunt amount is not correlating with the size of the ASD, it might be a bad marker rather than a good marker, because it could be a marker of an Eisenmenger syndrome. And we discussed the percutaneous closure, comment on the rims, the size of the ASD, any associated congenital anomalies, in specific the partial anomalous venous return. And thank you.